right. We can just go to the next slide. Thank you so much for this opportunity to give you an update on the work we've been doing. So much has happened quickly, suddenly, it feels like. Um, here's the crisis continuum, the national guidelines, someone to talk to, someone to respond, a safe place for help, following best practices. And we've made a lot of forward motion since 988 launched this summer. And in the mobile teams, we've launched the virtual care, and as of the 15th of this month, we will have our 6th county go live in the rural counties. So that's pretty exciting. We hope to go up to 11, but right now we're at 6. So that's pretty exciting. They're training live. They fly out, they train live, and work with our law enforcement in the rural counties. For somewhere to go, and we can kind of move to the next slide and look at that continuum. For somewhere to go, we're very excited to announce that the Bureau is in the process of finalizing the subgrant for the Crisis Stabilization Center in Northern Nevada in partnership with Renown. And then SB 390, this was the bill that was signed by the governor in 2021. In January, the Board of Health passed those temporary regulations to enforce the fee collection for the 35 cents. Those will go into effect at the end of February, and we expect fee collection at the end of May. Those are good through until November 1st, and then we will seek permanent regulations in summer. Oh, it looks like my other slide wasn't in. I apologize. I will talk about the RFI and the RFP. We have decided to move forward with an RFI prior to releasing the RFP, and we've decided to do that to better inform our RFP. So we expect to release that at the end of spring. And in the meantime, in the coming month, we are seeking some feedback from community partners so that we are ensure that our RFI and our RFP includes what the community partners are looking for. So not only a more cost-effective RFP, but also meeting the needs of our community partners. So that does push out our RFP likely till fall, but hopefully a more well-informed RFP in the end. And then here we see that we do have a monthly newsletter. We can reach out to Kendall to be put on that list. And then my contact information should be on the end of there. Thank you.
Great. Shannon, do you also have any additional? Or we're good?
No, Chair, I don't have anything additional to add.
Okay.
Just happy to take questions if you have them. Thanks for allowing us to be here today.
Of course. Any questions for the 988 team? Dr. Giron.
Dr. Giron, for the record. So what are you seeing? How are you hearing right now? What's your feedback? I have a lot of clients that are using it, and I'm getting mixed reports. So what do you think?
This is Shannon Bennett for the record. The call center specifically, like when they're calling 988, is that what you're referring to? Yeah, I think we have some areas that we can strengthen. And I think that once the request for information is done, and we really what the request for information is for is we want to see all of the vendors out there. We want to see what options they have for us. There's a lot of different ways to set this up, and we need a way that's going to fit for us and Nevada and all of our providers and all of the things. And then we'll do the RFP and get a contract in place with a vendor or multiple vendors or whatever that's going to look like. So I think at that point we'll be able to, and then the fee, right? So then we will have the fee, the revenue coming in from the fee. So we'll be able to dedicate some more funding to beefing up what this needs to be. So absolutely see areas for improvement, and we want to work through those. And I would love to hear more details about what you're experiencing. But we are up and running, and we look forward to continuing to enhance the whole work as we move forward. And we have a lot of, I imagine the next month or so, we're going to do extensive outreach to the community partners. We want to go to each regional board and a few other entities that I know of to discuss the RFI. So everyone kind of has an idea of what this thing is going to look like and what it's going to entail. And we're really focused there right now because you know, we will set the system up at the state level, but the implementation of the system will look a little bit different in each community, depending on what, you know, the 911 access is for each individual community and what that might look like for the interoperability, what mobile crisis teams are set up in each individual community, if there is a crisis stabilization center in each individual community or whatever that may be. So we really need a lot of community input as we move forward and take this into you know, building it out further.
Great. Any additional questions?
Commissioner Ficalora, since the mobile teams, the someone to respond, are already active in a number of counties, but the stabilization centers and someplace to go are not active, when someone responds and goes out to their community and they can't stabilize it in the field, where are they going?
Do you want to take that one, Shannon? Maybe you start and I'll come around and wrap it.
Sure. This is Shannon Scott for the record. Currently, the mobile crisis teams, or if law enforcement responds, depending on how that goes, they would take them to an ER, a CCBH, whatever is available currently, depending on their location. Hopefully not jail, but unfortunately how it's set up now, that is where they go. But the goal of the crisis response system is jail diversion.
So I think the answer there is it depends on the community. And again, this is why the community engagement as we build this out is really important, because it's going, we're going to have to move forward with what we have. We're going to have to get it set up with what we have and know and start and understand our gaps. I think we know a lot of our gaps already. I think more gaps are going to come to the surface as we actually set this thing up. I think at that point in time, we're going to be able to work on a plan to address it. We're going to see the revenue coming in. We're going to have an idea of how much that's going to be, and we'll be able to make more definitive plans as that comes to be. And each individual community will, you know, be able to take interest in setting up a crisis stabilization center or not. So I think a lot is left to be determined on how the details of it rolls out. But we have to start and build out from there.
Great. Thank you. I don't think we have any other questions at this time. So Shannon, thank you very much. Shannon Squared, thank you very much for your time today, and appreciate the report. We look forward to hearing future updates as we continue to move along. So thank you. All right, next agenda item number 10. It's an informational item. Update on seclusion and restraint denial of rights from DPBH. Joanne, are you here, or do we have a...
Good morning. Yes,
Oh, it was
Susan Lynch. I'll be presenting on Joe's
Susan?
behalf this morning for the
Great.
division. And thank you, Autumn. So we've got the presentation here, and I'll try to go through it fairly quickly. There's not a whole lot of outliers in it, but I'll try to point out some highlights and take some questions at the end. So Autumn, go ahead and skip through the agenda and then to this page. Okay, so this is the NAMS data. This is the data for Deanie Townsend in the north. And as you can see, it's their physical restraint hours. And you can see for the past quarter, they've not had any. So that's the green line, the observe rate that we're looking at in this slide. Next slide, please. And then this next slide is the seclusion numbers, and you can see a flat line for it. The seclusion as well for no hours used during this quarter and looks like for the entire year. So really good news to see that on a data chart. So next slide, please. And this is the SNAMS data. This is the physical restraint. And you can see that we've had some spikes both in, it looks like September and November for that. And typically what we see in our spikes is usually it's a unique individual having multiple incidents of or multiple episodes. So typically it's over the course of admission for one or two individuals that are just having some issues throughout their early days of their admission. Next slide, please. This is the seclusion numbers, and you can kind of see a little bit of that spike in November as well, but much lower numbers for the quarter for the seclusion. Next slide, please. These next two slides are really just the combination of the statewide, both Deanie Townsend in the north and Ross and Neal in the south, and so you can see those numbers there. Next slide, please. Again, same with the seclusion numbers here. Next slide. Okay, so this slide is the NAMS data for both their census numbers and their length of stay and also their wait list. You can see those numbers over the course of the last couple of fiscal years. Next slide, please. And that's the just a more visual of that same information. And this is the SNAMS information. And one thing I wanted to point out on the SNAMS information is if you look at the census going back to March 22, you'll see that the census numbers decreased going from in the 70s and 80s down into the 60s. And then you'll see another decrease in September where those census numbers decreased as well. And the reason for that dip in the numbers and dip in the clients that we saw during that time is that we shifted some beds and we shifted some staff as well over to the forensic side. And we'll get into that a little bit more with the wait list. But you can see in these numbers that as our census and our client beds for the civil side decreases, that our wait list has increased over these last few months. So we are having many conversations on our end and troubleshooting how to bring those wait lists back down and to and that wait list is both for misdemeanor diversion patients waiting in the jails as well as the ER numbers. So we have a couple plans in place to address those wait list numbers. Next slide, please. And this is the length of stay. Of note in this chart here are the spikes in June and July of 22. And this data is collected upon discharge. So what happened in the summer of 22 is we had two very, very long-term patients that were finally very successfully discharged back into the community. So that was the spike in the length of stay for those 2 months. And then you can see it kind of goes back down to our average of 2.5, 3 weeks length of stay. Next slide, please. Okay, it's the forensic facilities. And of note on this slide, as you can see, as of, it looks like about May of 22, the numbers shifted, and that's because Stein stopped accepting these types of evaluation clients at that point, and Lakes drastically cut back on those clients. So you can see those numbers there. Next slide, please. That's the same information. And next slide. All right, and these are the restoration clients. So these are the current census and the information data for the Lakes patients and the Stein patients as well. And you can see kind of that increasing trend over the last couple of years. And you can also see, if you look at the chart, you can kind of see in that March of 22, where the Stein numbers start a steadily increase. And that's because we did shift some of those beds over to accommodate the drastically increasing forensic waitlist. So if you also look at the waitlist column, you see those statewide restoration waitlist numbers going from double digits a couple years ago into the triple digits. That was one of our methods to try to accommodate the forensic waitlist, was to shift some of those beds over from the Ross and Neal civil side over to the forensic side. So actively working on decreasing our waitlist statewide. Next slide, please. This is that same information for the length of stay. And next slide, please. Okay, and this is about the end of the presentation. These are the long-term commitments at both Lakes Crossing and Stein Forensic Facility. And Lakes Crossing and Stein staff have worked really closely together over, well, probably forever, but definitely in this situation over the last few months. And we've, as I believe Drew mentioned in his agency manager report earlier, they're seeing higher numbers of commitments for these long-term commitments coming through Lakes Crossing. So we've had a large number of transfers from Lakes Crossing down to Stein Forensic Facility in the south to accommodate the increase in those long-term commitments. So here is the data on those admissions and those commitments. And again, with this, you can see that increasing trend over the years. And next slide, please. And that's just another visual representation of those long-term commitments. And again, you see kind of the straight line for a Stein facility in the south, and that's because this data is collected upon discharge. So you can see that since January of 22, there's not been as many discharged as previously occurred. And I believe that takes us to the end of the report, and I'm happy to take any questions.
Anyone have any questions for Susan? No? All right. Susan, thank you very much. Appreciate it. The question I had was already answered, so that just was why the spikes, but that makes total sense that it's, you know, one or two individuals and not part of a systemic issue or longer, bigger concern. It's just an anomaly of an individual. So good on my end. All right. Let's see here. We will move on then to agenda item number 11. It's an informational item and it's update on seclusion restraint, denial of rights, ADSD, and Marina. I believe I saw you earlier.
Hi, this is Marina Valerio, Agency Manager for DRC's ICF. My presentation is going to be very short. For the last quarter, we have had 0 restraints at the ICF. And so I will say it's a success story. I was asked to tell one earlier. And so I think for a while now, and I think why we're moving away from restraints is we implemented using blocking pads. So all of our homes have those in them. And if a person is starting to get upset, the staff are using those pads instead of putting hands on people. So that basically if somebody's going to harm themselves, they'll put the pad underneath. Like if they're going to hit their head, the pad will go into the area where they're trying to hurt themselves. Or if they're going to try to hit another person, the pad gets put in between that person and the person they're trying to hit. So they're actually not having to put hands on a person. So we believe that's the reason. But yeah, so that's our success story for today.
Great. Okay. Only question I'd have is with the blocking pads, are we seeing any injuries to like subsequent, injuries to either staff or the client, from torn rotator cuff? Something like that, any other minor or just any other things that I love the shift in, transition and finding alternative ways. And, allowing some of that energy to be released instead of the restraint where the energy is going to be contained, and maybe move through. But are we seeing any level of even just minor from anyone?
No, actually, I think, and I can go back and look at data, but I think we're having less incidents of staff injury.
Great.
In the past, we've had staff hurt because they've been hit or bitten. And so with this, we're seeing less of those type of injuries.
That's fantastic. And I see the commissioners nodding and thumbs up and everything else. So I think I speak for all of us saying that's wonderful news, and I'm glad we can do that. So any other questions or comments for Marina? Nope. All right, fantastic. We'll move on to agenda item number 12. This is another informational item. Update on Aging and Disability Services Division. Jessica, there you are. Jessica, the floor is yours.
Good morning, everyone, or I guess almost good lunchtime. Jessica Adams, Deputy Administrator for Aging and Disability Services over our developmental services programs. Just some quick updates on last time I presented on the various rates that we had put into our agency request budget. Happy to announce that all of those rates that I announced or that I talked about did make it into the governor's recommended budget. So hopefully we'll be seeing some increases to service rates, both that are given by our contracted providers and then also various family support programs, some of those family preservation programs, the fiscal intermediary program, some of those things that are just able to help keep families together, serving both kids and adults. Some of my staff were kind of talking about, rates and finding providers and that kind of stuff. It has certainly been challenging over the last year to find staff with our provider agencies. So you will see that our wait lists have gone up. I think at this point in time, they may be the highest they have ever been, unfortunately, for our residential services and our jobs and day training services. We've been able to do rates for certain people. So if we have somebody who's very difficult, we've been able to offer some higher rates. Very hopeful in talking with the providers and providers across the state that having ongoing rate increases like we talked about are going to help them be able to find staff, hire staff, and kind of keep our service system going. One of the things that you might see that we actually got more money in the governor's recommended budget than what we were able to put into agency request for those rates to our providers. That was based on the original rate study had been completed and we got it in June of 2021. I went back to that vendor that did it for us in August of 2022 and said, hey, obviously stuff has changed. Data that you were working on was mostly pre-COVID data. It was based, I think at that point, the Bureau of Labor Statistics data was coming back at an average salary of about $14.50 an hour for those direct support staff. As we all know, that is not going to get us staff in this current hiring environment. So I had them go back and rework the rates where all of those direct support staff would be paid at least $18 an hour. So $18 an hour, PTO, health insurance, making these into actual careers and not just a job that they're going to have for a little bit of time. So we were able, in talking with the governor's office, we were pushing for it. We had several providers working with them. They actually give us more money than we actually first asked for so that we can get up to those higher rates so that people can hopefully get paid at that $18 an hour. And we can see some movement on our wait lists and get staff going. So very excited about that. I don't know when the budget presentation will be yet, but excited to see that. I also talked last time about the $14.5 million that we got in ARPA funds for the new program of a intensive behavioral support home. I'm happy to announce that those funds finally did make it into our budgets. They got transferred over to us, so we will be starting on that. First step is getting a contractor to help us with all of that project and trying to write a RFP. And then I think the only other really update that I have for you, kind of going in line with the staffing issues that we're having. You've heard about all sorts of different staffing things going on. What I didn't share last time, we were able to also get into our governor's recommended budget. Marina has mentioned that at our intermediate care facility, which is the only 24-hour facility that ADSD operates, we have just had a large vacancy rate with our developmental support techs. Those are the people doing those direct services. What we have asked for and what got into the governor's recommended budget is for all of those. There's 4 different levels of a support tech, tech 1 through 4, and we've asked for all of them to get a grade +2, which is something that the state has done in the past, where when it's a really hard to fill job, at some point in time, that job was, set at a certain grade of pay. And if it's ongoing hard to fill, then the state has authorized a +2 for that grade. So for example, it would go from like a grade 23 to a grade 25. I think it's around a 5-6% raise. So we did get the go ahead to, that did make it into the governor's recommended budget. So we're hoping with those tech jobs that would permanently raise, or at least for the time, usually they end up being a permanent raise, would raise them up from a 23 to a 25 and then all the way up to a 31, I think, which should hopefully not only help us get staff, but really pay them for the type of work that is, because it's very difficult work. So, not only trying to help with our providers, but also trying to help with our own internal staff that are doing similar jobs. Any questions?
No, I think that's really encouraging, and it's great to hear some of the traction and movement that we're seeing with these budgets and caring for people. I just looked at my own numbers. When I first graduated, I was a service coordinator, a mental health service coordinator for a community mental health provider, and after we lobbied for a little bit of raise, I was making $720 every two checks. With a college degree, and that equals out to about $9 an hour. So times change, but it's good to hear that we're seeing that elevated rate and to be more responsive to the job market to get those folks where they need to. And I like your point of saying make it a career, not just a job, essentially. So, and I think that's we need to be looking towards that jobs are easy to get, or jobs can be easy to apply for, but how do we make these things careers for stability and getting back to what I said earlier, and that is there's people lives that are at the end of this, and if we've got constant staff turnover, we're not able to positively impact people the way we need to, regardless of what their role within the system is. So that's really great. So any other questions for Jessica this morning, or almost afternoon, lunchish? Lunch approximate. All right. Then we will close out agenda item number 12. I don't think we need anything for, I think we'll vacate agenda item number 13. We've taken care of most of that under agenda item number 7 for Commissioner Mosby. So I think the presentations and everything, we've got what we need. So I don't think there's any need to add that. So I'm just going to vacate that off our list and move to agenda item number 14 for possible action. Discuss, recommend, or approve nominee recommendations for current commission vacancy to fill the current or former recipient of mental health services provided by the state or any agency thereof position. I don't know if we have anything right now. Autumn, or maybe you or Sherry could shed some light on that, or if
Autumn Blattman for the record. So recently the divisions were tasked to review the different boards and commissions that we help oversee and provide support to. And part of that was identifying any vacant positions that were falling within the different boards and commissions. And of course, since you guys fall within my area of support, we noticed that there was, I don't remember if you remember, Sherry, but a couple of vacancies within this commission. And so we weren't quite sure how to go about finding recommendations for an individual who was a current or former recipient of mental health services. And so we were hoping just to bring this to the table to see if anybody had any ideas or would like to bring this back to their different individuals that they've had contact with to see if they would be interested in serving on the commission. So that's really it. We don't know if this is anything that you need to necessarily take action on today, but more to bring to your attention, see if you have any recommendations that you would be interested in bringing forth, and then we would be happy to take action to help that individual assistant applying with the governor's office.
Yeah, I agree, Autumn. I don't believe there's going to be any necessary action today. But just to echo Autumn, commission members and anybody on the call today, if you could search your databases, your Rolodex, if you still have one on your table. I've learned that there's certain periodic references that I make that some people look and go, what's a Rolodex? So if not, grab out your phone, find your telephone numbers. Your patient, old patients that you're aware of, somebody that you feel could be a great advocate and have an incredible voice on this board. I think it's a huge piece to have added that we currently don't. So just please reach out and do that. So that's it for now. I agree. There's no action, but we'll just say, hey, please help us out. So all right, we'll close out number 14 because there's no real action or vote to be taken at this time. And we'll move on to number 15. I know Commissioner Operario had to step away and is no longer here, but he was going to talk about the nursing aspect. So if we can just add that to a future agenda item and maybe reach out to him on a little more specific so we can make sure that the wording is correct, that would be fantastic for an addition. Does anybody else have anything at this time for this particular session to add? Autumn?
Thank you, Autumn Blattman for the record. So if we are going to table number 13 for the annual letter to the governor, if I could ask if one of the commission members would put that forth as another item for future agenda items, and that could possibly be something if we have a meeting in March or the special meeting about the other letter that you guys are doing, that we could work on next steps for that.
Okay. I think we should do that. I think our focus right now will be on the letter for the session, and I know we've got statutory times by which we want to have that done, but there's always been flexibility every year with that particular letter, and I think any letter that we would submit during this particular time is going to fall on deaf ears. Nobody's going to be paying attention to it, and there's a lot of work, the research, the data that we need to collect. So I think we'll hold that for the next meeting so we can start looking at that, and we'll have after Psy.D. I don't think we will. I think submitting anything prior to Psy.D. And really having everybody else work on it, because everybody's going to have their needs through the session, will be, I think, just a little challenging and difficult, and also knowing that we've got the new governor and he's still settling into his role. I want to make sure that I know he's got an agenda. It's clear from some of the proclamations and letters and other things that everybody has received that he's got some things he wants to work out first. I think while this is important for him, other things are going to take a certain priority, and so we'll hold off until then. So I would say let's look to add that to something late spring to begin working from there. Yeah. And Autumn, you and I can look at what the dates are, and then we can finalize when that'll go on. But that's my recommendation, unless there's anybody else that has an alternative thought. Okay, great. Fantastic. So those would be the only things. And I guess we'll move on to number 16, which is going to be public comment. As we spelled out before, I won't reiterate that, but just to give the synopsis, public comment is limited to 2 minutes. If anybody has public comment, please share here. Autumn's information is in the chat box, or you can place an item in the chat for comment as well. Do we have anyone with public comment at this time? All right. Seeing and hearing none, we're going to close out public comment, and I am going to adjourn the open session here. We'll give a 5-minute bio break, and then we'll move into our closed session here in 5 minutes. So let's look to come back at 12:05, and we'll go from there. Thank you, everyone. Have a wonderful day. Enjoy.
Autumn, if you could hear me, are we using a different link for the closed session?
Yes, Dr. Ravine, we are using a separate link.
All right, thank you.
If you need that sent to,
Yeah, I have it. Thank you.
Okay,
Wanted to
perfect.
confirm it.
yes,
Thank you.
thank you.